So here we're going to learn the neuroanatomy of eye movements. And we've already seen a lot of this in our cranial neuropathies tutorials. We're going to focus on extraocular movements, the final common pathway, and then the pupillary light reflex. And we're going to use the pathologies as a way to reinforce the physiology we're going to learn here. So starting off with extraocular movements, we're focusing on the somatomotor set of cranial nerves. So that's 3, 4, 6, 12, and 11, and we're going to focus only on 3, 4, and 6. These are midline cranial nerves. Remember, their nuclei originate in midline, and the nerves then are sent out, generally speaking, in midline. 4 has that opposite thing because it decussates immediately, it crosses to the other side immediately, and then extends out laterally. So these are the 6 cardinal positions of gaze. Cranial nerve 3 is the major workhorse here. We represent it in purple. It innervates the inferior oblique, superior rectus, medial rectus, and inferior rectus extraocular muscles. So what ends up happening in a cranial nerve 3 palsy is that the eye is down and out. And that's because the eye cannot rotate upward, nor can it rotate inward. And the eye is actually affected in its downward gaze as well, because when the eye is rotated out laterally, that's when inferior rectus is activated to move the eye downward. So this is an setup of a patient with an oculomotor palsy. We'll see at the end how the eye is down and out. This side here, the eye is normal. On this opposite side here, the eye is abnormal. So the patient is being instructed to go through the 6 cardinal positions of gaze, and ultimately we see that the eye is very constricted, and at its rest state, it's down and out. Now it's down because the eyelid is down because of levator palpebrae denervation. This is in opposition to, in Horner syndrome, the superior tarsal muscle is denervated. But in a cranial nerve 3 palsy, it's levator palpebrae. So what about cranial nerve 4? So in a cranial nerve 4 palsy, in a trochlear palsy, the eye is drifted upward. And what this generates is a vertical diplopia because the eyes are at different heights. So the image then is at different heights. In order to bring the image into, to remove the diplopia, to have a singular image, the head tilts so that these eyes are brought into a singular axis here where the image is no longer separated vertically. So what about cranial nerve 6? It innervates the lateral rectus, which moves the eye outward. So in a cranial nerve 6 palsy, the eye is unable to rotate outward and is drifted inward here. And the important clinical point here is that when there's pressure on the brainstem, there's stretch on cranial nerve 6 because it's pinched here at Dorello's canal. So that causes denervation when there's downward herniation or pressure on the brainstem itself. So now let's move on to the final common pathway. So in the final common pathway, we have frontal eye fields, we have the eyes themselves, we have the midbrain, the pons, we have the abducens nucleus, medial longitudinal fasciculus, and then the oculomotor nucleus. In this instance, the left frontal eye field is driving the eyes to the right. In order to produce that, the left frontal eye fields innervate the abducens nucleus here, which has 2 pools of neurons, motor neurons, which innervate the ipsilateral side, the right side, causing the eye to deviate outward, because remember, abducens nucleus, or cranial nerve 6, causes eye rotation outward. And then there are interneurons, which project across, back across. They decussate to the original side here, channel up the medial longitudinal fasciculus to the oculomotor nucleus, innervated by cranial nerve 3, and then that innervates the ipsilateral side, the left eye, to move inward, because remember, cranial nerve 3 innervates medial rectus, which moves the eye inward, and in that way, the frontal eye field drives the eyes to the opposite side. So let's look at some pathologies as a way to reinforce this physiology. So first, what happens if the eyes are unable to deviate to one side? Well, where could the lesion be there? Well, in an oculomotor nucleus, On the right, for instance, the eyes would be unable to deviate to the right. And that's because both the motor neurons and the interneurons are affected. So what about if the right eye is able to deviate outward, but the left eye is unable to deviate inward? Where could that pathology be? Well, if there's injury to the medial longitudinal fasciculus, then those interneurons are unable to pass to the opposite side up to the oculomotor nucleus, and we call this an internuclear ophthalmoplegia, and it will also have an associated nystagmus in the normal eye as one of the clinical findings. We can see this actually in both eyes in what's called a bilateral internuclear ophthalmoplegia if both medial longitudinal fasciculi are affected. We often attribute internuclear ophthalmoplegia, or we assume that it could be from a demyelinating plaque, because demyelination doesn't follow a vascular pattern, and we can see demyelination in multiple sclerosis. So internuclear ophthalmoplegia is often a potential indicator of multiple sclerosis. Finally, what happens if the only thing that the eyes can do is one of the eyes can deviate outward? So basically a half of the movements are still preserved. Well, the injury could happen if we have an abducens nucleus injury that also tracks all the way out to affect the medial longitudinal fasciculus. Then of the two full potential movements, 1.5 of them would be knocked out, denervated, so we call this 1.5 syndrome. So finally, let's look at the pupillary light reflex. So in the pupillary light reflex, the pupils constrict in response to light. So light comes in, it's captured at the retina by the optic nerve. The optic nerve then sends projections to the pretectal olivary nucleus, which then sends projections bilaterally to the Edinger-Westphal nuclei of cranial nerve 3. And then cranial nerve 3 projects to the ciliary ganglia, which then send projections via the short ciliary nerves to the sphincter muscles, which cause the pupil to constrict. So that's the basic physiology. Let's look at some pathology. So if we see a dilated pupil, we're suspecting that there's injury to the pupillary light reflex pathway. Just to remind ourselves, sympathetic innervation causes pupillary dilation. That's from the iris dilator muscles. Parasympathetic innervation via the sphincter muscles causes pupillary constriction. So the first potential source of a dilated pupil is short ciliary nerve or ciliary ganglionopathy. We call this an Adie's tonic pupil. The way that we can distinguish these various potential causes of pupillary constriction is to look at their response to cholinergic agonists. So if a weak amount of cholinergic agonist, a weak pilocarpine, is able to cause the pupil to constrict, we think of an Adie's tonic pupil, we think of ciliary ganglionopathy. And the reason is that in this setup, there's going to be supersensitivity. Because of this denervation, there's now supersensitivity here in the eye itself to cholinergic agonists. If the pupil's still dilated, however, and then we give strong pilocarpine and we see that there's pupillary constriction, then we know that the problem isn't in this anterior machinery within the eye, but the problem is actually in cranial nerve 3 itself. So we know that we have an oculomotor palsy. If we still give cholinergic agonists and nothing happens, then we know that there's something blocking pupillary constriction in the anterior machinery here. So we think of a muscarinic antagonist, a pharmacologic innervation that's blocking our cholinergic agonist here. Now let's look at an eye that is abnormally constricted. We look at this with Horner syndrome. In Horner syndrome, there's ptosis, eyelid droop. Remember, this is the superior tarsal muscle in Horner syndrome. And then there's miosis, pupillary constriction, and then there's also anhidrosis, a loss of sweating. There's a variety of different places that this can occur, from the hypothalamus to the brainstem to the superior cervical ganglion as a Pancoast tumor. carotid dissection can cause denervation of these sympathetic fibers as well. All of this causing pupillary constriction. So that's a quick trip through neuroanatomy of eye movements, obviously really core to the neurological exam.